Hello and welcome to Ask the Professionals Q&A. My name is Heidi Sittelmeyer, and I am the Director of Online and Community Connections here at the Arthritis Foundation. I facilitate a Live Yes Connect group in West Los Angeles, and I'm also a patient living with juvenile rheumatoid arthritis persisting into adulthood, and I now also live with osteoarthritis and a couple of other comorbidities. So Ask the Professionals Q&A is an interactive video series where we solicit questions from the arthritis patient community and then bring them to leading experts to help get our questions answered. Today, I have the pleasure of having Dr. Marcy Bolster, and she is a rheumatologist and an associate professor of medicine at Harvard Medical School in the Division of Rheumatology, Allergy, and Immunology. She is the co-editor of the book, Facing RA, Guide for Patients and Families, produced by Massachusetts General Hospital. Other titles in the series, also edited by Dr. Bolster, include Facing Lupus, Facing Scleroderma, and Facing Osteoporosis. The books are available on Amazon. So welcome, Dr. Bolster.
Thank you so much, Heidi. It's really a pleasure to be here with you, and I look forward to the questions that you'll pose to me.
Great, so we're going to dive right in because we've got lots of questions about inflammation and disease management. So first off, can you define inflammation? I know people often use swelling and inflammation interchangeably. Is that correct?
That is correct. I think of inflammation, I go back to actually when I learned about it in medical school, and there are 4 components to inflammation. There's swelling, redness, warmth, and tenderness. And so all of those components can be present in a process that's causing inflammation, though it's not required to have all 4 components to qualify as inflammation. So certainly when people describe swelling and inflammation as similar terms, I think that's likely correct. I will add, though, that sometimes people can have swelling that's related to non-inflammatory causes, such as when a patient has a swollen knee that might relate to osteoarthritis, which is not an inflammatory type of arthritis.
Terrific. So what role does inflammation play in the disease process for autoimmune types of arthritis like RA, psoriatic, or ankylosing spondylitis?
Inflammation is a key player in those types of arthritis. Patients with the types of arthritis that you mentioned are all considered to have an inflammatory arthritis. And when we use the term inflammatory arthritis, that's to pull in that the patient has the presence of inflammation. And typically the presence of inflammation is in the joints or in the spine, as in the patient that has the axial spondyloarthropathy or ankylosing spondylitis is that other term used.
Great. And does inflammation play a role in fibromyalgia or gout?
Well, let's divide that out. Most people don't think of fibromyalgia as being involving inflammation. There's a lot to be learned about fibromyalgia, but our knowledge to date does not include that it's an inflammatory process. Gout, however, is highly inflammatory. And that is one of the types of inflammatory arthritis. Gout, I would put in kind of the bucket of crystalline arthritis. And that can be gout, or there's another type of arthritis called pseudo-gout, which means like gout. And those types of arthritis are caused by the deposits of crystals in the joints that cause inflammation.
What medications have the best evidence to scale back inflammation for autoimmune arthritis and gout?
Okay, again, let's separate that out. I wouldn't lump gout into, gout is a metabolic problem. So the crystalline arthritis conditions are thought to be more metabolic and not autoimmune. Now, that's not to say that the immune system isn't involved, because the immune system's involved when there's inflammation. But there are a lot of medications that specifically target the immune system, and those aren't the medicines that we typically think of for gout. Gout gets treated with treating the inflammation and treating the underlying problem of a high uric acid in the blood. The other types of inflammatory arthritis that you brought up before in the kind of autoimmune category, such as rheumatoid arthritis or psoriatic arthritis or ankylosing spondylitis, are treated by targeting different parts of the immune system. We know that there are these very inflammatory, we call it pro-inflammatory mediators. And what that means is that there are basically chemicals or molecules in our blood and involved in the joints that that are related to inflammation and even cause more inflammation. And so by specifically targeting those different mediators, we have found great efficacy or effectiveness in treating the underlying arthritis. But I'll also add that if you see a picture, maybe even a cartoon of all the different inflammatory mediators that are involved in an inflammatory type of arthritis, such as rheumatoid arthritis, there are also some medicines that might target some of those mediators that don't actually work to treat the underlying problem of the rheumatoid arthritis. So it's a very complicated kind of cascade, or if you picture kind of all these interconnections to come up with a good treatment.
Thank you. I know it definitely is complex, when we talk about cytokines, interleukin 6 inhibitors, IL-1 inhibitors, it's like enough to make a layman's brain like explode.
And you mentioned some really important mediators. I didn't even talk specifically about them, but you're right. There's the interleukins, like interleukin 6, and then there's tumor necrosis factor, the TNF inhibitors. There are other inhibitors that inhibit one type of cell, the T cell that's involved in inflammation, so T cell co-stimulation. There are other inhibitors that inhibit the B cells. There are numerous types of biologic agents that target those different mediators, but there are also, I would say, older conventional synthetic medications that aren't as specific for targeting those mediators, but are very effective for treating rheumatoid arthritis or psoriatic arthritis. And that would be a medicine such as methotrexate, which has been our gold standard for treating inflammatory arthritis, such as rheumatoid arthritis.
Great. Yeah, there's so many medications now. And, I'm a bit of a dinosaur, right? So back in the old days, there wasn't such a, you didn't have so many different choices.
That's right. That's right. We're very fortunate that there are so many choices. And patients who were diagnosed, many years ago really didn't have all those options.
So we definitely have a lot better outcomes now. So, so we've talked a little bit about some of the medications that impact inflammatory arthritis, but what about inflammation in OA? I know we touched a little bit on it, but is there anything else you can say around that?
Yes, osteoarthritis or OA is thought to be a non-inflammatory type of arthritis. And I say that because, we started out with inflammation and swelling, and it's not to say that people that have osteoarthritis don't have swelling. They can have swelling, particularly in the knee, but it's not clear. It's been called a non-inflammatory arthritis, and it has been termed degenerative arthritis or wear and tear arthritis. But as research continues about osteoarthritis, it seems that there may be an inflammatory component to it. And just as we have what we call DMARDs, which are disease-modifying anti-rheumatic drugs, and you and I were just talking back and forth about the different DMARDs, there's the hope that we'll have DMODs, or disease-modifying osteoarthritis drugs, so that we could actually modify the progression of the disease for people who have osteoarthritis. It's not clear if that will be by targeting inflammation. It may be targeting a different component of osteoarthritis that may relate to the cartilage or to another component within the joint. But we tend to say that we don't target inflammation in treating osteoarthritis. But before you ask, because then I know the question comes up about the non-steroidal anti-inflammatory drugs, the NSAIDs. And it's interesting because they do target inflammation and we do use them for osteoarthritis. But NSAIDs also have analgesic properties and what we call antipyretic or treat fever. So NSAIDs treat inflammation, pain, and fever. So 3 different components. And certainly they can be helpful for the pain of osteoarthritis. And if there is a little component of inflammation, perhaps they also help that.
All right, great. And I think really sort of tied along the same lines is, can regular use of over-the-counter medications work to help lower inflammation, like, baby aspirins or aspirins? I'd be related to what type we're talking about, right?
Well, aspirin can reduce inflammation. And in fact, we were talking a moment ago about how many years ago we didn't have all of these fancy biologic medicines. And many years ago, likewise, we used aspirin in very high dose to treat inflammation. So yes, it can treat inflammation, and the non-steroidal anti-inflammatory drugs can treat inflammation. And so people that have gout, for instance, can have a very nice response to using the non-steroidal anti-inflammatory drugs. We don't tend to use the high doses of aspirin any longer because the toxicities are so high related to the doses of aspirin we would need to be anti-inflammatory. But the non-steroidals, we definitely do use them to treat inflammation. When you ask about osteoarthritis, it's not clear that the NSAIDs are treating inflammation. But when you talk about gout or pseudo-gout, the crystalline diseases, the NSAIDs can be a tremendous help in making people feel better because of their very potent anti-inflammatory properties.
Terrific. Thank you. So the next question is, can arthritis inflammation impact other parts of the body?
Definitely. We know that when patients have an inflammatory arthritis, that there's involvement of the joint. But then there's also the possibility that patients could have what's called extra-articular manifestations. And what that means, extra in this sense means outside of, articular means the joint, like arthritis, and manifestations would be the way, features of a patient's presentation. So patients can definitely have problems related to their arthritis that affect more than just the joints. And for instance, people can develop inflammatory eye disease, and that can be seen in patients with rheumatoid arthritis, in patients that have lupus or psoriatic arthritis or ankylosing spondylitis. All of those diseases, sarcoidosis, can have inflammation of the eye. There are many other organs that can be involved that are obviously outside of the joint, like the lining of the heart, and patients can get pericarditis, or the lining of the lung, and patients can get pleurisy or even fluid on the lung. Patients can get involvement of the blood vessels that causes vasculitis, which is inflammation of the blood vessels. They can get involvement of the nerves that can cause damage to the nerves that go to the hands or the feet, or a neuropathy. So there are lots of different parts of the body that can be affected even outside of the joints.
Thank you. So next question from our patient community is, why do my labs show that I still have inflammation even though my disease is well controlled with medication and I have little pain?
That's tricky, isn't it?
Yes.
We always want to treat the patient. So the fact that you're doing well is far more important than the labs looking abnormal when you're talking about inflammation particularly. So we would follow the patient. But I think it's important to also consider, could there be something else besides the arthritis that's driving the inflammation? So there are other diseases that a patient could have, such as an infection, that could drive the signs of inflammation up, but the patient could feel fine from the underlying inflammatory arthritis.
Now, vice versa, another patient asked, why do I still have pain even though my inflammation levels have gone down, my labs look good, and my disease is well controlled?
Again, I would treat the patient. So I would see how the patient's doing. And the other thing to consider, I don't really know the time periods that these patients are asking about. So labs can lag behind clinical course. So the patient could have been having very active disease, get their disease under control, and the labs can kind of tootle along and take a little time to improve. But for the patient who's having symptoms, even though the labs look better, it would be, so there, I think a couple ways to think about that. It could be that their underlying inflammatory arthritis is actually better because, say, the inflammatory markers like SED rate and CRP have gotten better, but there are lots of reasons why that patients can experience pain. So a patient may also have osteoarthritis, and to the patient, there's still pain, and they still have joint pain and stiffness. And so even though the inflammatory component is better, there are still reasons that the patient could have pain, whether it's bursitis or osteoarthritis or some other kind of arthritis.
Thank you. Next question. Are there any natural remedies to help scale back inflammation, like turmeric, fish oils? Somebody even asked about green tea matcha powder.
Right. Those are all really great questions. I think that the nutritional supplements do not get the same rigor of study that our medications do. And so having a firm answer is often more difficult. There have certainly been some studies looking at turmeric and fish oil, and they very well may reduce inflammation. They're unlikely to cause harm. So if a patient finds that using those foods or supplements is helpful, then I think that's fine. There is the caveat. I mean, I think you need to consider that what form would you be using to take those supplements? And the over-the-counter remedies are not, they don't have the same FDA regulations that our prescription drugs do. And so supplements they don't have to be pure. They don't have to even contain what you think they're containing. So I think it's important to ensure that the source for these supplements is a reliable source. The supplements are unlikely to be harmful. I don't know about green tea matcha powder, but I think the supplements are unlikely to be harmful just as long as they are represented by what you think they're taking, what you think you're taking.
The person further went on to ask, what would be a therapeutic dose and what is the best form to consume these remedies, whether it's fresh, powdered, or pill form?
Yeah, I don't think that I'm able to answer that. I think that's probably better discussed when we start talking about doses. I think that's probably better discussed on an individual basis with the patient's physician. Perfect.
All right. And then our next one is, are natural remedies safe for children? And what is the recommended dose amount of inflammation lowering supplements to give to children? Now, I've got a feeling I know the answer is going to be on that one again.
I'm not a pediatrician, so I don't think that I can give advice for children with arthritis.
The next question, any suggestions other than medications and supplements to help ease pain and swelling in inflamed joints?
So yeah, there are a lot of things that you can do that I would term non-pharmacologic. So the question writer asked about things that are outside of medications or supplements. And to me, that means non-pharmacologic. And that would include things like exercise or physical therapy or occupational therapy. And I'll address each of those. Exercise is incredibly helpful for people that have arthritis. It helps to strengthen the muscles around the joints. It helps to improve heart health. It improves energy, it improves sleep. So exercise is so important for people with arthritis. It needs to be undertaken in a safe way so that patients aren't at risk of injury, and patients shouldn't try to overdo it and decide they can just go walk 5 miles if they haven't been walking, but to start slowly and build up slowly. And honestly, exercise should be advised and discussed with the patient's doctor to make sure what they've decided to do is safe. Physical therapy is a form of exercise where it's therapeutic exercises to address specific problems with specific joints. Example, for a patient who has back pain, physical therapy can be incredibly helpful for addressing the back symptoms, and the physical therapy can target strengthening exercises such as core strengthening, which can help them with posture and with the spine and with the back pain. Similarly, people that have arthritis in the knee or in the hip can perform specific physical therapy exercises to strengthen the muscles around the knee or around the hip, and that can help with the pain that the patient experiences in that joint. And then likewise, occupational therapy, that differs in different regions of the country, but in some places, occupational therapists really focus on the hand and the arm, and they can be involved with splints. So patients that have arthritis, for instance, at the base of the thumb might benefit from wearing a splint. And so seeing an occupational therapist could be helpful. So those are all non-pharmacologic ways to address joint pain or arthritis.
Great. And what about some at-home remedies, like maybe hot cold therapy? Would that be beneficial?
I usually advise patients if there's inflammation like a tendonitis or a bursitis, I have found that ice is more helpful for that. Heat may feel better kind of temporarily with that, with an inflammation from bursitis or tendonitis, but it can often end up kind of worsening the symptoms. So I think that ice for that type of inflammation, whereas for joint pains such as osteoarthritis, typically, ice is helpful for the knee, for instance, if a patient has overdone it. But some patients with osteoarthritis in the hands, which causes kind of the knobby look of the fingers and can cause discomfort and stiffness, a lot of times patients like paraffin baths, and that's very soothing for the hands. And likewise, when it's more muscular in the back or the neck, patients might benefit from moist heat so that the heat gets delivered with moisture that helps to relax the muscles that could be contributing to the pain.
Yeah, my microwave rice pack.
Yeah, exactly.
One of my favorite things. All right. How about medical cannabis and CBD products? Can those help decrease inflammation? Is there evidence for that?
Oh, that's really an area that needs a lot more study. I think we have all seen information pouring out about the use of CBD and could that be helpful for inflammation? Could it be helpful for pain? And I just think it needs more study. I'm sorry to say this is going to be an area where I'm not going to be able to make specific recommendations, because I think that a really important part of considering the use of CBD is, first of all, does it treat inflammation? Does it help pain? I mean, that's what the question's about. The second part is, what does it do related to the other medications a patient might be taking? And we certainly wouldn't want to add something that is not regulated to medications that are very highly regulated and prescribed when there could be drug interactions.
All right. So the next question from our community is, can diet help dial down inflammation? If so, which foods can be eaten and which should be avoided?
I think diet likely is an important part of how people feel. Whether it has to do with inflammation is, I think, harder to know. what I will advise my patients who ask about diet to observe heart healthy diets. And that would include, say, the Mediterranean diet, where there's more of a focus on vegetables, fish. They're still including meat, but limited red meat. Some people really feel much better on plant-based diets. And so a plant-based diet would be one that excludes meat altogether or even animal products. So I think it's a matter of finding what each person can do and likes to do. I don't think I can recommend specific foods to eat or to avoid. In general, I think, avoiding high carbohydrate content foods and avoiding high fructose corn syrup, which has been associated with an increased risk of gout. I think that those are good foods to avoid. And the high fructose corn syrup foods would be drinks like soft drinks. But it's hard to know because there's so many things that interplay with diet, and people have so many different factors that go into how they're feeling and the degree of inflammation. So I think it does make sense to be heart healthy, and the Mediterranean diet. There's also the DASH diet that's been recommended for patients who have gout, and again, the avoidance of high fructose corn syrup containing foods.
Thank you. Okay, our next question from a patient in our community is, what causes sudden pain flares in OA? It's been confirmed by x-rays. And why is it that during these flares, all joints hurt and not just one or two that have been overused?
It's hard to know what causes a specific flare for a patient, but often in patients who have osteoarthritis, the trigger for a flare can be, as the patient questioner asks or suggests, is overuse. And in this way, often patients will develop much more pain, for example, at the base of the thumb after they've been busy in the garden or cooking in the kitchen or cleaning or helping to, with a move or something that really involves the hands a lot. Patients that may have a flare of their knee pain may get that after overuse, for instance, after travel, if they've been doing much more walking than usual. So it's not necessarily always clear, but typically it has to do with the use of the joint. Why do other joints hurt? Why isn't it just the knee? Well, that's probably complicated. If there is overuse of one area, your whole body's moving, so there may be overuse in other areas as well. But the other important part of that is that when a patient isn't feeling well, they may not be sleeping well. So if their hands are bothering them, they may not be sleeping well, or if their knee is bothering them, they may not be sleeping well. And then that disrupted or non-restorative, non-restoring sleep can make people feel bad and achy all over.
Thank you. And I know for myself, even if my knee is flared, I walk differently, right? I'm compensating. So then the hip and the low back start hurting too. If it's,
that's a really important,
days,
That's a really important point, Heidi. Thank you, because the mechanics get altered.
Right.
As you compensate, as you say, you walk and your gait is different, and that alters the mechanics and everything else. And so that can be contributory. That's definitely true.
Yeah. So, everything's connected, right?
Everything's connected. That's right.
All right. And the next question from our patient community, and it's a sort of specific one here, is any recommendations for people with eye inflammation or uveitis? What about people who are unable to take biologics or steroid drops? Are there any other medications that can help?
I think this is such a specific question, and I don't think that I'm able to answer that in an academic enough way. I think that problem really needs to be addressed by that patient's physician and specialist. So that would likely involve the ophthalmologist and the rheumatologist.
Thank you. Yes, and we definitely have a healthcare team when we're dealing with inflammatory arthritis.
That
Multiple specialists talking to each other. Perfect. Well, that was actually our last question. I want to thank you, Dr. Bolster, for your willingness to come in and tackle these questions from our community. And we really help you, we really appreciate you helping to educate our community.
Well, Heidi, thank you so much for asking me to participate in this way. I've really enjoyed it. I appreciate the questions. And I know that patients ask questions when they're seeing the doctor at their usual office visits, but there are so many questions that come up after the visit, and it's important to try to address those. And I would encourage people to continue the conversation with their providers. And Heidi, as you said, it's a team. It really is a team approach. The primary care doctor, the rheumatologist, often there are other specialists that may include ophthalmology or orthopedic surgery, but there are also people to help with education in the physicians' offices, the nurse practitioners and PAs and nurses. So it absolutely is a team effort.
Well, I definitely appreciate your final thoughts. And yes, it definitely does take a team to keep us moving and grooving, as I say. So for
again, and I look forward to perhaps seeing you again in the future.
Perfect. Thank you. So do I. So, so for next month, you guys, we're going to be tackling another topic, but I'll release the topic on October 1st. So we invite you to come back to the Ask the Professionals discussion on the online community, where you'll see what that topic is. And to learn more about the Arthritis Foundation and the awesome programs and services we provide to our community, please visit arthritis.org. You'll learn more about our patient education webinars. We have our podcasts. We have the Connect groups that are meeting virtually currently. We have our online community, our Insights program, and our Vim app, which is an awesome new tool that is available on Android and your iPhone. I can't find my phone or else I pop it up, but it's a great new tool where you can set goals, and we have great educational content in there, and there's a whole community we're building there. So thank you everyone for joining us today.